Welcome, everyone. Thanks for joining today. Hope you guys enjoyed the music. Gotta love a little Dolly Parton to get us started. Welcome, everyone. Today is, what is today? Is today Wednesday? Is that today? I think we're Wednesday. Yes, today is Wednesday, July 27th. We are here for the Society of Thoracic Surgeons General Thoracic Surgery Database User Group call. Again, thank you, everyone, for joining today. Let's see here. I'm sorry, let me pull up a couple of more things on my end. Sorry, everybody. All right. Okay, for today's call, we are have our same old agenda, welcome and introductions. I'll provide a brief STS update. And then actually I'm going to turn things over to Katie Lothrop. She is doing a analysis report overview today. So she's going to give us a walkthrough of our most recent report and just provide some insight on how to understand the report, how to use the report. So we appreciate Katie very much for doing that for us today. After Katie's report overview, we're going to turn things over to IQVIA to provide an update. And then, as usual, we'll finish off with user feedback. If you have any questions, please put those into the Q&A, and we will get those answered for you. But again, please use the Q&A and not the chat for your questions. Also, we have the raise hand function enabled. So if you would like to raise your hand and just talk and ask your question that way, or if you need to clarify anything, again, please use that raise hand function, and we will get you unmuted. And just be sure to unmute yourself on your end, and then we can just have a quick conversation. On the call with me today from STS, we have Carol Crone and Ruth Raleigh, and of course, Katie Lothrop from our core group. And from the IQVIA side, we have Joffrey, Jean, and Joe. So thank you, everyone, for joining today. Let's go ahead and hop into our STS updates. Again, not a lot of new information as compared to our last call, so you won't see many changes here on these slides. For training manual, of course, that has the training manual for July has been posted. And again, if you do have questions, please do submit your questions via the Q&A. I know there's other conversations, there's other calls. I believe, like the EDDI calls, that sometimes questions will come up. And of course, those EDDI calls are not STS sponsored calls. So if you have questions, please submit your specific questions to the FAQ. That allows us to address those questions on any variables that you're having concerns about. Once you submit those questions via the FAQ, Ruth can get those answered for you, and then Ruth can bring them back to the core group, and we can discuss them with the surgeons. And again, get clarification placed into the training manual. So again, if you have any questions about any of the variables, please reach out to us via the FAQs. That's what Ruth and team are here for, to help you get those questions answered. Spring 22 analysis results, as you are aware, those reports were released. Partial reports were released. We released the lung and esophageal composite report, and those were made available on July 11th. The participant results for the benchmark and legacy reports will be released separately. Those reports are in UAT testing, and that does begin this week. So we are looking at those reports and testing those. So hopefully those will be, once this UAT is complete, those reports will be coming within the next few weeks. And of course, the communication will be sent out to you all when those reports are available in the IQVIA platform. Of course, any report-related questions should be directed to GTSD tech support at IQVIA.com. Again, just submit those questions directly to tech support, and STS will be looped in as needed. So again, please submit those report questions directly to GTSD tech support. The fall 22 harvest is currently underway. That harvest is set to close on Friday, September the 9th at 11:59 p.m. Eastern Time. So please be sure to get your data submitted and for the fall 22 harvest prior to 11:59 p.m. Eastern Time. So again, we encourage you to submit that data early and often. Opt out is Tuesday, September 13th. So you have until Friday, September 9th to get those harvest files in. And then if you If you choose to, you can opt out by Tuesday, September the 13th. Of course, just a reminder, the fall 22 harvest does include OR dates up through June 30th of 2022. Of course, that's Q1 and Q2. And I just wanted to bring this up just to clarify, to ensure that we have equitable comparisons between the participant risk-adjusted results and STS benchmarks. Sites do need to have at least one case within the new 6-month time frame to receive risk-adjusted results. If you're not able to submit data for the most current 6 months for Q1 and Q2 for the fall 22 harvest, we do recommend that you opt out of the current harvest. If you have any questions related to that, please feel free to reach out to me directly. Happy to talk with you about that. But again, the fall 22 harvest does include OR dates up through June 30th of 2022. And of course, as stated earlier, we really do encourage you to submit that data early and often. Make sure that data is clean, pay attention to those mortality thresholds, make sure your mortality variables are clean, not missing data. So again, if you have any questions, please reach out to us and we're happy to assist in any way. All right. IQVIA platform access, as you guys are aware, if you're adding new users or deactivating current users, please complete the STS participant contact form, and that can be found out on the STS website. If you have any questions about completing that participant contact form, please reach out to our team at STSDB@sts.org, and Addie would be happy to assist you with getting those forms completed. GTSD public reporting, as you're aware, the public reporting website was updated on July 11th as well. If you have not been out to the STS public reporting website, the website does offer some new features, and these include graphed participant credible intervals. We also have interactive maps, as well as enhanced search functionality. So if you have not been out to the STS public reporting page, we do encourage you to go out. If you have any public reporting related questions, please reach out to Sydney Clinton directly. Her email is listed here. She can be reached at sclinton@sts.org. And again, Sydney handles all things public reporting, so please reach out to her directly. The 2022 audit is currently underway. Sites that were selected have been notified and the audit is in progress. For those selected sites, if you have any questions regarding your audit, please reach out to CRS directly. If you have any questions in general about the audit, please reach out to Emily Conrad. Emily can be reached at eConrad. I'm sorry, I didn't put her contact information here, but we can put that in the chat box. Emily can be reached at eConrad@sts.org. All right, sorry, it sounds like we're doing some lawn maintenance outside, so I apologize if you guys can hear that. I also wanted to do a quick review regarding AQO. As you all are aware, our data managers meeting is October the 26th through the 28th. It's located in Providence, Rhode Island this year, and we are very much looking forward to being in person. Here is our listing of prices, STS members versus non-members. We also have our early bird pricing. And of course, that early bird registration is available up through Friday, August the 26th. Also, the general thoracic session is going to be held on Wednesday, October the 26th. Of course, we are offering the in-person track as well as the virtual pass. Obviously, we would love to have you join us in person if you are able. Of course, I just wanted to point out the key differences between in-person and virtual pass. I know many of you have heard this before, but in case we have new people that are joining, the virtual pass is not going to be a live stream of the in-person meeting. So if you do choose the virtual pass option, all of the live and in-person sessions will be recorded, and that archive will be available to you all in mid-November. So you'll have the ability to watch all of the in-person sessions via those recorded via recording. CMEs, continuing education, all of that is still applicable for these recorded sessions. after in November, we'll be bringing back all of our live speakers. We're going to have about an hour or so long webinar in January, where you all will have the opportunity to ask questions from our presenters from the in-person meeting. So we will again be having the webinar in January to bring back our AQO hot topic speakers. So also regarding AQO, we do have those block of rooms that are reserved. So we do encourage you to go ahead and reserve your room. We have our special AQO group rate. And again, that rate is guaranteed through Tuesday, October the 4th, or until that is sold out. For those that have not heard, AQO is going green this year. So all materials will be posted prior to AQO and available for download for you to bring those materials with you. Excuse me. I know on the last call, we did do a poll for AQO in regards to attendance. Our marketing has asked for a little bit more specific information, so I'm going to run another poll. So if you guys could take the opportunity for the next couple of minutes to complete this poll. Let me go ahead and launch that. All right, you should be able to see the poll. Our first question is, again, are you planning to attend AQO 2022? If you're not able to attend, just obviously check no, not able to attend, and then go down to question 2. And if you did select no, not able to attend, just click the NA. I plan on just click, what's the option? Other, Carol? Is that what it is? And then you can click submit. So you have to answer both questions to fully to submit.
That's right, Lee,
for the poll.
Other is the answer.
Okay.
If you're NA is if you're attending in person, and other is if there's another reason that's not listed and you're not planning to attend in person.
Yep, thank you.
Yeah.
You have to scroll. You have to scroll all the way down to get all the choices. It's a little bit tricky.
Yeah, there's
Thank
lots
you,
of
Ruth.
choices. Thanks, Ruth. There's lots of choices. Yeah.
So again, thank you guys. I know we did a poll last time, but again, we just want to provide our marketing with as much information as possible. We greatly appreciate it. So I'll let this run for another minute. So, all right, looks like we still have about 67 of 89 have submitted. There's some more questions. There's some more responses coming in, so I'll wait just a couple more. Give everybody the opportunity. About 79% have answered. Few more seconds. Every time I say that, the numbers slowly tick up. We're still going up. All right. Still going up. Looks like we have some people that just joined within the last minute, so I'll give them the opportunity to respond. All right, so I'll give it a few more seconds and then we'll go ahead and end. All right, we have about 87% that have responded, so I think that's good. All right, I'll go ahead and end that and share the results. So again, thank you everyone. So far, it looks like we're about 15% in person, with the majority actually not able to attend this year. We do have about 30% looking at virtual option only and around 11% who are still undecided. So again, thank you guys very much for completing this. We greatly appreciate it, and we'll share these results with our marketing team. So again, thank you all very much. All right, so let's go on to our next, and that is all that I have for now. So I'm going to turn things over to Katie so she can provide the analysis report overview. And for those that are not aware, Katie Lothrop is one of our STS core group members. She has been working with the STS National Database as a core group member for very many years and is very familiar with these reports, and we greatly appreciate Katie taking the time to provide this this overview for us. So, and of course, Katie is out of Providence Portland Medical Center out on the left coast. So thank you so much, Katie. So the floor is yours.
Thanks, Leanne. Can you hear me okay?
Yes, ma'am.
Okay. Well, thanks for asking me to give this presentation, and hopefully you won't regret it when I'm finished. But I just wanted to quickly state here that what we're doing today is just a basic overview of the reports. We will not be getting deep into any of the statistical and analysis or discussing any of the technical details of the risk model. I'm not a statistician. I don't pretend to be. And so we're going to leave that discussion for the experts. So if you do have specific questions pertaining to those things, you can feel free to ask them at the end and we can make a note of them. Anything we can't answer, then we can take those notes down and have the appropriate people respond. So primarily this is it's for everybody, but we really want to help new data managers or, those longtime data managers that might still struggle with understanding the reports. So I'm just going to try to go over quickly what we have available, and hopefully it will be straightforward and concise. So you can go to the next slide. Thanks, Leon. So this is obviously something we're all familiar with. This is just the IQVIA's, the risk adjusted dashboard homepage. So when you click on that, this is where you come to. We're going to go through the first 5 reports that are under the lung cancer section, and then we'll highlight the lung cancer resection composite as well as esophagectomy composite at the end. And I just want to also, when I was creating this, there was no data in like the dummy participant dashboard. So what I'm showing you today are going to be just screenshots. And so I apologize that there's no like dynamic live reports, but we will work with what we have here. So, okay, next slide, please. So first, we're going to start with the participant performance for lobectomy compared to STS and NIS. That is the first report on the dashboard. So NIS, most people know, but if you don't, it stands for National Inpatient Sample. And they provide the most generalizable data that represents the lung cancer resection outcomes on a national level. And we have 2 outcomes that can be or domains that can be directly compared, and those are discharge mortality and post-op length of stay. I want to point out, though, that even though STS typically reports on operative mortality, what we're comparing here is just discharge mortality, which is a death prior to discharge, or what we call a hospital death. And operative mortality, which we're more familiar with, is both hospital death and a death within 30 days of surgery. And also, with our current version, that also now includes discharge to hospice. And then the other part of this report, or the other thing that's included in this report, is the minimally invasive lobectomy for clinical stage 1 lung cancer. Note that this also includes TIS cases. And we do not compare this to NIS because there is no cancer staging available in the National Inpatient Sample. Okay, next slide. Okay, so sorry, this is kind of blurry. And again, most of you, I'm sure, have seen this. This is just a screenshot of the way the entire report looks. We're going to be breaking this down into sections in the next few slides. But I just wanted to show this. This is the full report and what it looks like. Next slide. So the first thing we're going to look at here is discharge mortality. So we have that as our domain. And I want to note here that this information here is not risk adjusted before we go forward here. So for this participant, the N indicates the total number of cases included, which is 101. Number of PAT, or number of patients, is the number of patients who experienced a discharge mortality. So for this particular participant, it was 0. And then the score reflects that percentage, which is 0. The 95% credible interval, and I know the chart says confidence interval. For this presentation, we're going to use them interchangeably. So you might hear me say confidence interval, you might hear me say credible interval, you might hear me just say interval or CI. It's all this going to be the same thing. But this is the range in which the participant's true score is likely to be. Then we have, if we keep going over, we have the STS and NIS with their scores of 0.5% and 1.02%. And then the chart below obviously displays this same information. And STS and NIS, they also have their N, their total number of cases, and then the number of patients that experience a discharge mortality, and NIS has their information there on the far right as well. And then the chart, you can see here that your site or the participant is the solid black line, STS is the red dotted line, NIS is the blue dashed line. And so you can see that the participant in this particular report has better than expected results. Their line is right on the 0. So that's why it's kind of hard to see, but it's there. And I did cut it off, but the better than expected results are towards the left. And that will be on your actual report when you look at it. Okay, next slide. Okay, so the next portion of this particular report is post-op length of stay. Again, you're going to see your N as the total number of cases, which is 101. The median or the middle length of stay is what we report on here. It's not the average. And so what that means is that, I mean, this is obvious, but the median means that half the scores are lower and half the scores are higher. So for this particular participant, their median was 2 days. And then we have the first and third, or Q1, Q3, which stands for the first and third quartile. And quartiles are essentially values that divide a list of numbers into quarters. So here, the Q1 is representing the lower quartile and Q3 is the upper quartile. And then the median is essentially Q2 or the middle. So median days for STS was 3, and for NIS, it was 3.8. So again, you can see that this is represented here on the chart below with the lines, and you can see that, again, this participant is to the left, so they have better than expected results. And you can also see here in the chart that the min-max for STS, that is that light blue line, which is the whole thing right now because of the way the slider is. And then the dark blue or darker blue interval is that the Q1 to Q3. So that's what those stand for. So, okay, moving on, next chart or next slide. Thank you. Okay, so this is the minimally invasive lobectomy for clinical stage 1 lung cancer report. And just a quick statement about this. Normally you have your discharge mortality and the minimally invasive on the same report together. I tried to filter out the discharge mortality information so it was clear and we're just looking at the minimally invasive information, which is why it might look different than what you typically see. So, but again, here our N is smaller because this is obviously a smaller cohort. So these 71 patients are all of your clinical stage 1 lobectomies, which includes TIS, and whether open, VATS, robotic, doesn't matter. So all of your clinical stage 1 lobectomies make up this 71 here. And then the number of patients, so 66, that represents the number of those 71 cases that were resected using a minimally invasive approach. So that gives this participant a score of 93%. Again, we have our 95% credible interval here that shows us the high-low range for the participant. And we can compare that to the STS score, which they have 85.9%, and they have slightly over 21,000 cases, and a little over 18,000 of those were done minimally invasively. And this particular chart at the bottom here, it also will say better results or better than expected results are to the left because it includes the discharge mortality information also. However, that statement does not apply to this domain. There's not really a better or worse when it comes to this particular outcome, but this participant did have a higher percentage that were done minimally invasive than STS for this reporting period. And so you can see that their black solid line is actually to the right because it's a higher percentage, but it doesn't mean that this was less than expected. It's just because their percentage is higher. So I also want to make a note too that this particular domain does have other exclusion criteria. So in addition to the clinical stage, this only includes elective cases and cases that weren't missing any of the required fields. Also, other exclusions were ASA of 5 or 6, occult or 0 pathological stage. And this information you can find in your analysis overview. I believe it's on page 6 and 7. Okay, so next slide. So now we're going to move on to everybody's favorite, the lobectomy for lung cancer composite quality rating, which we also know as star rated report. So I'm going to briefly go over the inclusion criteria here, which I think most of us are familiar with, but we would have a primary category of disease of lung cancer, either upper, middle, lower, or unspecified. And then your primary procedure is going to either be an open lobectomy or a VATS lobectomy. And again, all of these are elective cases, so no urgent or emergent lobectomies in here. Exclusions are any records that are missing the required fields. Again, occult or stage 0 pathologic stage, ASA of 5 or 6. And this one, we have exclusion of ECOG or ZUBROD of 4 or 5. So 0 through 3 are your ECOG score or ZUBROD are the ones that are going to be included here. Also excluded are participants with 2% or greater missing or unknown for the discharge status and status at 30 days. And also, as most of us know, you have to have at least 30 eligible lobectomies in order to be included in the 3-year, or in order to get a star rating for this 3-year harvest period, for any 3-year harvest period. Okay, thank you. And again, the information regarding the inclusion and exclusion is on page 9 and 10 of the analysis overview. So again, this slide is just a screenshot of what the full report looks like. We're going to break this down again, and all of the statistical calculation and details for the composite are also in the analysis overview, which most of the information I'm giving today is from that overview. So I would encourage you to get familiar with it because it helps. It really helps in your understanding of these reports. Okay, next slide. So before we get into the actual details of the report, I just wanted to go over the 3 reported domains that are in our composite, which is absence of mortality, absence of major complication, and overall, which is the combined morbidity mortality. And then on the right-hand side here, you can see this is the list of the major complication endpoints that we use. I just want to make a couple notes about this, that reintubation is listed here, but actually it's respiratory failure is what that element is called. It's been that now for a few versions. This is where we capture reintubation, but that is not its current name. Also, unexpected return to OR is the wording from version 2.3, if you go back that far. And then it changed in 2.41 and again in 5.21. So right now we know it as post-op procedure through new or existing incision. And we're going to talk a little bit more about that event in a little bit, as it's more than likely impacted your star rating in potentially a not so favorable way in the last few years. Okay, next slide. Okay, so this is the first part of the report here. So we see the domains we've already discussed here on the left. Then we have the participant star rating, and then we have their score, and a higher score or a higher percentage indicates better quality. And then we have our 95% credible interval here. Then going further down, we have STS, we have their score, which is the average score of all participants in the analysis. And then we have the min-max, which denotes the estimated lowest and highest participant scores in the analysis. And then we have the 25th, the median, and the 75th, which just denote the percentiles of the distribution across participants. So it's where all the participants lie within all of the STS. So if we go back to the participants information here, we can see that they have 2 stars in all domains. But first, I just want to talk about their scores first, or their percentages. We'll talk more about the star ratings in just a minute. So the scores are 98.62, 98.99, 92.72. And so these are telling us, what this is telling us is that this is the proportion, the percentage of patients who would not experience this indicated adverse outcome or the domain if the participant treated a large number of patients. Okay, you can go to the next slide. So here we can see where our information from above is sort of like plotted on the chart. We have the participant being represented by the solid black line again, and we have STS as the dotted red line. We have the min-max of STS, which is that light blue section, and then we have the participant's credible interval in the darker blue. So this participant's results are better than the STS average in all 3 domains, because you can tell obviously the percentages were higher, and you can see that the black line is to the left. However, this particular participant's results were not significant enough of a difference. There wasn't a significant enough difference to obtain a 3-star rating, which is why they all had, each domain had 2 stars. Okay, next slide. Okay, so I want to just get into the star rating a little bit more here. So if we look at this side, we can see that how they're labeled. So 1 star is worse than expected, 2 stars are as expected, and 3 stars would be better than expected. And what the 1 and the 3 stars tells us is whether or not the participant's score is significantly different than the STS average. So if a participant's score is higher than the STS average, like we saw in the report we were just looking at, but the difference is not statistically significant, then they're still going to get a 2-star rating. If it's higher than the STS, like it is, and statistically significant of a difference, then that's when they would receive a 3-star rating. And this works the same for lower scores and receiving a 1-star rating. Also, one thing to note is I know a lot of people especially our surgeons, get hung up on the stars of this, the 1 and the 3. But what's important to remember is that outcomes for STS participants are better than national averages. So this is important because if you're a hospital with 2-star rating, which is at an expected level for STS, and your surgeons are bummed about that and they feel like they should be a 3-star, it could be that they are considered a high performer when they're compared to national outcomes from all hospital. And similarly, if they got a 1-star rating, which would show worse than expected or below expected level for an STS participant, that could actually mean that they're just more of an average or as expected performer when compared nationally. So that's something to keep in mind. And it's also important to note that star ratings for the participants very likely can change from one harvest to the next. And this is because the comparison for a specific time period and the participants' outcomes and STS average all have the potential to change each time the analysis is performed. So volume impacts that comparison also. So those participants that have lower volume will potentially have less stable results when compared to a higher volume participant. So this is kind of also why we say there's no specific like magic number or percent that a person or a participant can aim for to guarantee a 3-star rating. It really depends on how they compare to the STS average for that given time period. And because of that, and because of all of the differing case mixes for each participant, that's why we also shouldn't compare our scores to other participants, because everybody's case mix is always going to be different. So I know that even this was very wordy, and I know there still can be some confusion about the ratings, the star rating and the intervals and all of that. So, or you might just have surgeons who don't understand and they see that their score is higher than the STS, and they automatically think that they should be 3 stars. And I know I've run into this personally myself as well. So I wanted to show a couple of examples of both 3-star and 1-star ratings, although I'm sure no surgeons are out there aiming to be a 1-star performer. But I just want to show an example, and hopefully it will make sense. This is the way I try to digest and understand it. So hopefully it will help you as well, or maybe your surgeon or whoever might ask for the information. So okay, so here we have a participant with 2 3-star ratings, one for the overall and then one for absence of major complication. And I will note here that just because you get a 3-star in the combined, like the overall domain, it doesn't necessarily mean that you got 3 stars in absence of mortality and absence of major complication. It doesn't work like that. So anyways, so what we have is, so for the participants' overall score, so that top line here, they received 99.10%. And if you look over, their interval is 98.39 to 99.58%. That's their credible interval. So because the lower limit of their interval, which is 98.39, is higher than the STS average score, which is 98.31, then it's at least what we say is 97.5%. Sorry, there's a lot of percents here, but it's 97.5% likely that this participant's true performance exceeds the STS average. And we say 97.5% because it's that 95% credible interval plus you have 2.5% upper tail and 2.5% lower tail. So 97.5 is that 95% plus the 2.5% upper tail. Anyways, so, and there's a great illustration of this on page 15 of the analysis overview that I should have included here, but I didn't. So please look at that for yourself. It helps explain that a lot better. Oh, thank you. There it is. So I think this can be a little bit clearer also if you look at the chart below. So if you can see where the overall is, you can see that the participants line and the entire dark blue area, which is the participant's credible interval. Then you see how the STS line sits not only to the right of the participant, but it's completely outside of that dark blue interval. So this means that we have our interval, we've exceeded the expectation. So we are above where the STS is even in our interval here. So if we look at, if we go down to the third one, absence of major complication, you can see again, the participant score is 95.02. Their credible interval is 91.16 to 97.72. Because the lower limit of their interval, which is 91.16, is higher than the STS average of 91.12, they get 3 stars. Again, you can see this here below in the chart where the STS is not only to the right of the participant's black score, but it's sitting entirely outside of their confidence interval. Okay, and then going on to, if you go to the next slide, I'll show an example again of 1 star. I won't go into each domain here since we just did that, but essentially it's the same thing, just reversed. You'll actually be looking at the higher limit of the participant's credible interval. So for the overall, you can see that the participant score was 97.11%. The interval was 96.12 to 98. And the STS average was 98.10. So the top end of their interval at 98% was less than the STS score of 98.10. So they get 1 star, and you can see that on the chart below, where this time you have the STS red line being to the left. So we know that that's better. And it's completely outside of the participant's credible interval. And you can see the same thing for absence of major complication at the bottom, although you can't even see the participant score, but that's just because of where the slider's at. So I know that's kind of a lot to digest, and hopefully I didn't confuse you even more, but that is how I kind of look at and digest the information. And that's how I've tried to explain it to my surgeons. And sometimes they get it and sometimes they don't. Okay, next slide. So this is the lobectomy for lung cancer composite quality rating details. This is the kind of more granular data that your composite score is derived from. So we can see we have the same domain, the same 2 domains, and we have your eligible procedures, the detail, which lists out each complication that's tracked here, as well as operative mortality. The count, which is the number of records that either had a mortality or experienced a major complication. And I do want to note also here that if the patient had more than 1 event, so say they got pneumonia and had a trach, you will not see it listed under pneumonia and trach. They are going to fall under that, the more than or multiple complications, that second from the bottom row, because that's where they put anybody that had more than 1 complication. So, and then the blue numbers that we have here for the counts, those are all hyperlinked. I'm sure you guys know this. So if you click on them, you get that patient drill down that displays below, and you can go into each individual record, which is a very helpful feature, I think. And we did talk about this earlier on slide 10, but this is kind of where I wanted to come back to. Is that due to the definition change of the unexpected return to the OR over the years, specifically with version 2.41, these numbers are most likely at some point you've seen them, what it probably appears to be inflated, because we were capturing a lot of minor things like chest tubes that we never collected here before. So if your number's high, don't fret, you're in good company. It probably just means that you are abstracting accurately. And as we get further away from version 2.41, that number should hopefully drop down and be more of a true reflection of what that definition is now. Okay, next slide. So this is the lung cancer staging procedures report. There's not a ton to say here. It's pretty self-explanatory. This has your all your clinical staging methods broken down by year. You can click on the little arrow here where it says clinical staging done, and you can select different things, and it will update the graph or the chart here to display different information. I will note that I know there is a known issue with this, where the 2021 percentages are reporting lower than they should be. Just FYI on that. So, okay, that's pretty much all I have to say about that chart. Next one. Okay, so the last report that we'll go over in detail today is going to be our risk-adjusted outcomes. And why do we risk adjust? Well, it allows us to compare the outcomes from the database in a way that adjusts for the differing case mix, which is what we talked about a little bit before. And that's important because, as we all know, there's varying volume between participants. It can vary drastically. And also, there are some participants who might just kind of by default treat a higher number of patients with either more severe illness, or perhaps you have a large number of patients who travel from really remote locations. Maybe you're in Alaska or something like that. And maybe they haven't received much medical care, so they're in poor health. And keeping them in the hospital longer after their surgery is actually safer than sending them home somewhere far away too early. So by adjusting for these things, the participants aren't penalized for treating higher risk patients that might be more likely to die or have post-op complications or a longer length of stay. And this is also why abstracting all of the preoperative history, including our ECOG score and our post-op events, is really crucial for the most accurate outcomes. Okay, next slide. This is what the risk-adjusted outcomes report looks like. Again, same stuff. We have our eligible procedures. Then we have our unadjusted rate of 0 because, well, for operative mortality, I'm just going to use that top line. And then their rate was 0 because they had no deaths. And then we have the risk-adjusted rate, which is the outcome rate that would be observed hypothetically if a patient's risk-adjusted performance on its own case mix was extrapolated to the entire population of the STS database. And then we have our 90%, 95% credible interval again, and then the STS risk-adjusted scores as well. And then obviously same stuff for major complication. And then again, it's all graphed out at the bottom. That's okay, I'm done. So the next slide, so that's it for the, going over the main reports. The other two that we have as far as the composites, we have new is the lung cancer resection composite rating. And I'm just going to go over, rather than going through all the details, because it's pretty much all the same. I just wanted to talk about the inclusion and exclusion criteria, which is all here. You'll see it's pretty similar to lobectomy with just the addition of category disease. They've also included lung cancer main bronchus. And then you can see your primary procedures. We have all of our lung resections available here. And then similar to lobectomy, we have the same exclusion information, and they have to have at least 30 eligible procedures within that 3-year period to receive a star rating. Next slide. And again, then for esophagectomy, similar, but obviously different because this is a completely different group of patients. So we've got a different set of diagnosis. So these are your esophageal cancer diagnosis are required. We have our primary procedures. So it has to be one of these diagnosis, one of these primary procedures, elective again. We have some additional exclusions pertaining to staging that will potentially exclude your case from the analysis. And for esophagectomies, participants need to have 15 eligible procedures in that 3-year harvest period to receive a star rating. And that's pretty much it for me. So there are other reports for esophagectomy, but again, they are similar in explanation to what we covered with the lobectomy reports.
Katie, thank you so much. I don't know if you've looked at the comments so far, but everybody's very grateful. Super helpful presentation. So thank you very much. We do have some questions, but I want to give Joe the opportunity to provide his update really quickly, because I think it does answer maybe one question in the Q&A. So Joe, go ahead.
I'm sorry to interrupt, Leanne. Can I ask Katie a quick question before we get off of the thing? I think it might be helpful for everybody, or we can explain it together. I often get questions, Katie, this is Carol from STS. I often get questions about how my site was a 3-star, 2 3 stars, and then part of the other composite may have been a 2-star. Maybe they had 1 3-star, 1 2-star. Their overall comes out to be a 2-star. Do you ever have questions like that in general thoracic? Or are your star ratings strictly based on the composites? So you have general thoracic, primary lung cancer composite, and a primary esophageal cancer composite, and you don't see the separate star rating for the endpoints that go into those composites?
I'm trying to understand. I'm sorry, I'm not. So are you asking, do we get questions about why one domain would have 2-star and why one would have 3-star in the same report? Or
I guess, are there separate domains reported out for the primary lung cancer composite where you receive star ratings?
Yes. So you mean compared to like esophagectomy?
Can you go to the lung cancer, to the star rating, what a star rating? So let's say that the site received, for this screen, the site received absence of mortality, they received a 3-star. Absence of major complication, they received a 2-star, but their overall was a 2-star. They oftentimes ask, why is it that I could get a 3-star, but my overall might be a 2-star? Or it could even be that their overall is a 1-star. And usually the way that I explain it is that if their absence of mortality outcome was closest, like that blue box, the confidence interval or credible interval, the STS score was right on the edge of that box, meaning that they received a 1 or 2-star because of that. It was very close to that next rating, which is oftentimes the lower rating that they would have received. So it depends where that STS score falls in relation to the credible interval for general thoracic. And if you're right on the cusp of receiving the next lower score, and then the other domain that goes into that is also right on the cusp of receiving the next lower score, it is likely that your overall score will be lower because of that. I'm not sure if I'm making sense. I'm kind of talking in circles, but
I'm kind of following, but not exactly. There is a good, I'm going to try to find it. There is a good explanation in the overview. I'll try to find where it's at and I can post it in the comments that kind of explains a little bit like why it's not just like, oh, I got essentially kind of like what I commented before was that just because you might have a 3-star in the overall, which is the combined, it doesn't necessarily mean that both the other 2 domains are going to be 3 stars, because it's not just like they take them and add them together and then divide it like 3
correct.
and 3, you know.
And the reverse is true. If you have 3 stars in 2 of the categories, if they're right on the cusp of being between a 2 or a 3-star, it is possible that you would receive a 2-star for overall.
Correct. Yeah.
We've had participants that, exactly. They get a 3-star for absence of mortality, a 3-star for absence of major complication, but yet the overall is only a 2-star. So, but yeah, exactly. It's not an average of the 2. Just throw them together and get an average of the 2. So, exactly.
Thank you.
Yeah.
Sorry for being confusing. I was trying to explain it and I got lost in envisioning adult. But yeah.
No, great. That's a great point, Carol. Thank you. All right. Okay, Joe, did you have a couple updates if you wanted to give those real quick, and then we can finish up with questions?
Yep, sure thing. Thank you very much. Good afternoon, everybody. As most of you should be aware by now, on July 9th, we did release the spring 22 harvest results to the database, which can be found under GTSD risk adjusted dashboard report under operational reports in the system. To kind of support that, we did also post an updated version of the analyses report overview in the library, and also the spring 2022 GTSD harvest composite quality rating summary has been posted there as well. As you are likely aware, we did have to temporarily disable the export and print features, so your reports cannot currently be exported with the export report button. However, we did distribute by PDF by email copies of those reports to sites. So if you did not receive a copy of that, please let us know and we can get that out to you. Just send an email to the GTSD tech support at IQVIA.com address, and somebody can pull that for you and respond. Also, note that it is possible that if your site opted out or did not have results for your most recent report, you would not have received a report by email. All right, next slide. There are 2 issues that we are aware of at this time in regard to the results of that spring 2022 harvest. They are similar items, STS 8562 and 8563, related to lung cancer staging procedures and esophageal cancer staging procedures, respectively. The report logic needs to be updated to include the version 5.21.1 data version changes. for some of the variables, which were discontinued and replaced with updated variables. So those updates are still pending. And because of that, some of your results may not currently reflect what you expect to see. So those are items we are aware of and working on, and we will get those resolved as soon as possible. And I think that's it for me. Yep, just so usual reminders, report anything that you need to. Let us know what's going on if you have issues or if you're looking for an update on something you've reported, and we will post known issues to the notifications as soon as we become aware of them.
Great. Thank you so much, Joe. So we've got a couple of minutes left. We have a few questions. The first one was, please show how to export and print this report. And I know you just covered that, Joe. The print and export feature is currently disabled, so I can't show how to do that right now. But I know Melanie, and I'm not sure if it's in the library yet, Melanie and team were working on instructions for exporting and printing the PDFs, the report into PDF. And it's like I said, I don't know, Joe, if that's available in the library just yet, but we will let you know when it is available. Also, again, that export function is disabled, and that will be enabled currently once these benchmark and legacy reports are available to you all. But if you have questions specifically of how to export and print, even when the functionality is available, if you reach out to tech support, they can happily walk you through that and show you directly how to do that. But since it's disabled right now, I'm just not able to give a show you exactly how to do that. So I apologize. What does overall actually include in the composite? So, and I think Katie did cover that. And there's also, I think your question was answered, Tammy. I'm not sure, but it's a combination of those two domains. If you want to know how that overall is calculated, that information, it's a little above my head, but it is in the analysis overview of how that overall composite score is calculated. So if you'd like the details on that actually can be found on page 13 of that. I think it's in the overview for each composite. For each specific composite, it tells you how those overall scores are calculated. Hope that answers your question. If you're currently displaying, I think Katie touched on this too, if you're currently displaying a high unexpected number based on past versions, how does this affect your star rating, if at all? And as Casey did cover, it does affect your star rating. And if she indicated if you were coding it correctly based on the definitions at that time. But once we do move, we get out of the 241 and previous versions in the analysis, those you should see a decrease in those numbers for unexpected return to the OR. So I don't know, Katie, if you had anything to add.
No, not really.
Yeah.
But yeah, you pretty much covered it. It is going to affect it, unfortunately, but there's nothing really we can do about it until we get past 2.41.
And you're not alone if it isn't. So just aware, you're not the only one. Our next question from Dawn, Katie. Thank you, Katie. Super helpful. Under the composite rating details, when I click on a complication, my drill down gives me a patient list, but I can't open each case from there. I have to go in and search each patient by their record ID separately. Should I have the option to click on each record and have it open within the report? Yes. I don't know if Joe or Joffrey, if you guys could, when you click on the details, I don't know, Joe or Joffrey.
When I click on a complication.
So when you click, oops, sorry, going the wrong way. So you click on the details here. I'm assuming this is what she's talking about. So when she clicks here, it gets her drop down patient ID. But when she clicks on there's a hyperlink, down here for each record, and it should take you to the record within the platform. You should be able to see it within the platform. And I don't think it is. Oh, so you do have that option, right?
I don't think that. Just looking at the bottom of that screenshot, the columns available in that case list, I don't see an access case column. So I don't think there currently is an option to directly link the case in that case list.
Okay.
So I think if that's something that we were able to add, we would have to be an enhancement request.
Okay.
But I don't think that ability is built into the report as it stands.
Okay. All right. Dawn, if you could submit that to tech support as an enhancement request to add that feature, that functionality, then that way we can get it tracked and we can have a list of it, and then we can cover that on our calls with IQVIA for report enhancements.
And I think the reason, this is the risk adjusted report, correct?
Yes.
I think the reason it doesn't is because the risk adjusted report for most of the data goes off of the harvest data. So it's
Right.
going off of data that has been sent for validation and then returned. So it's not specifically linked back to the IQVIA database for the live cases that can be updated within the application. It's kind of more of a snapshot in time.
Right. That makes sense. Thank you, Joffrey, for pointing that out. Are ECOG scores reported in the risk adjusted report? I don't know that off the top of my head. ECOG scores reported in the risk. I don't know the top of that off the top of my head, Barb. So are you looking just like a breakdown of how many patients had that ECOG score? I don't think that's in there at this time. If that's what you're asking, so let's go sort of be an enhancement. Okay, so it would be an enhancement. So at this time, it's not. So we can definitely look at if that's on the list, and that's one of the items that we will review for an enhancement, Barb. All right. Thank you. All right. We are a couple minutes over, and I just want to be respectful of everyone's time. Upcoming webinars, our next monthly webinar is August 10th at 1:30 Central, and our next user group call is scheduled for August 24th at 2:30 Central. Thank you so much to Katie today for that presentation. Obviously, everyone is super grateful for that. You did a phenomenal job, and helping with our understanding on how to use that report and understanding the report. So again, thank you so very much for taking the time to do that presentation and present for us today, Katie. Thank you.
You're welcome.
Thanks everybody for joining. We'll see you guys next time, and I hope you all have a great rest of your day. Thanks everyone.